Well, hello and welcome to a Wednesday morning coffee with Dr. Childress here. So I'm just about to get underway with some report writing, and I figured I'd check in with you about something, a thought, because I can. I love the internet. I love YouTube. So right now my next task is to do a final kind of look at a report I'm sending out that's going to have Appendix 1 and catalog of concerns and checklist and everything, and final summary and analysis report for a forensic custody evaluation. So I've been working on that the last couple of days, getting that all done, and I'll be sending that out this morning, next thing. And then my next task is to another report that I'm about halfway through, three-quarters of the way through. So I need to write that summary analysis report, get that one out is the next task. And then I got one coming in. So that's my day as I start my Wednesday here. I've got my cup of coffee. And as I was getting to work, I thought it's pretty basic. Everything about the solution is very, very, very simple. And so I thought I would share another bit of simplicity. Right now, my entire practice is serving as a second opinion review of court-involved mental health professionals. My goal is to increase the quality of the mental health professionals that are serving you, that are in the family courts. And so I'm doing that by serving as a second opinion review of the current work product that is being generated by your mental health professionals, particularly the forensic custody evaluators, the reunification therapists, and now I'm turning additionally to the individual child therapists. And I'll talk about that this Sunday. I'm planning this Sunday's talk to talk about individual child therapy. So what is individual child therapy? Behavioral therapy, play therapy, neurodevelopmental therapy. What's out there? Basically, is nothing. There is no child therapy outside of the family courts. There's no child therapy, but I'll talk about that this Sunday. But I'm doing second opinion review of the mental health professions. Now, as a second opinion doctor in the healthcare system, think about if you have a medical problem and you go to a doctor and they give you a diagnosis and you go, well, I don't agree with that diagnosis. You go seek a second opinion on the diagnosis. And so that's healthcare, that's doctors. And I'm a doctor, and that's what I'm doing. So the first thing I'm going to do with all these reports, the one I just sent out, the one that's coming in, the one I'm currently writing, is I'm looking, and based on the symptoms that they're reporting and the context and everything, I think they misdiagnosed the pathology. Yeah, I think it's a shared delusion, factitious disorder, child psychological abuse based on the symptoms they're reporting. So, as a second opinion, I'm going to challenge their diagnosis. Okay, that's pretty simple. Okay, they do an assessment, they come back with their conclusions. I say, I don't think those are supported. That I'm going to say that's a misdiagnosis. Now, as soon as I do that, they have an obligation as doctors to support their diagnosis, defend their diagnosis, basically. So if you think about grand rounds at a hospital, you see those physicians in the TV shows, and you're walking around with a bunch of your interns and doing your patients, staffing your patients at bedside. The senior doctor there would say, okay, what's the diagnosis and treatment plan? And the intern would tell what's going on and have to defend their diagnosis, based on stuff. And so that's what's happening, is a challenge to the diagnosis. But what that means right now, and what that's going to show, is that they first have to diagnose something before they can reach the level of a misdiagnosis. Okay, so not only have they misdiagnosed it because they missed everything, they didn't diagnose anything. So obviously they missed whatever it is, and to not to have confusion about what their diagnosis is to have to guess what the doctor's diagnosis is just really, really bad. You should never, if you go into your physician, you should never have to guess what their diagnosis is. If you get a judge, because they're the same role, judge in the legal system, doctor in the healthcare system. If you get a judge who has a trial, clinical evaluation, has a trial, renders a verdict, diagnosis, and it goes to an appellate court, second opinion, there should be no confusion in the appellate court as to what the verdict was. Okay, the evidence and everything else is independent. What's the verdict out of the court? Is it guilty or innocent? There should be no confusion about what the verdict of the court is. There should be no confusion about what the diagnosis is. And yet, I'm doing a second opinion review and I'm not seeing a diagnosis. That's why we have the DSM-5 ICD-11 diagnostic systems, is for clarity in professional level communication. It's not for the public. We don't have the DSM-5 and the ICD-11 for the general public. We have it for the doctors. So the doctors have a way of communicating, and that's established diagnostic criteria when we apply them. We all know what schizophrenia is. We all know what bipolar is. We all know what, delusional thought disorders are. And so that's why we do it at a professional level. And we have doctors in the family courts, these forensic custody evaluators, who are not applying the DSM-5 and ICD-11 to their diagnostic formulations and judgments and things. That's in violation of 2.04 of the APA Ethics Code, to apply the established knowledge, and DSM ICD-11 is established knowledge. They're not doing that, so that's a violation of ethical standards. And there's a reason for ethical standards. This is exactly it. If you don't apply the established knowledge, everything just goes to the bottom. Okay, so let's get it back up to a baseline. APA Ethics Code, Standard 2.04, DSM-5, so that when Dr. Childress comes along as your second opinion, and I will be, because these parents are bringing me in on your cases. And that's their right as a litigant in the court. It is the parent's right as a litigant in this situation to challenge your diagnosis. That's what they're doing. So they're bringing me your report. I'm looking at it and going, yep, I'm not seeing it. I'm not even seeing what your diagnosis is. And that's going to be bad. I have a whole section, a whole area of concern in my catalog about no diagnosis. Okay, and I've already got that, and it's just going to be getting better and better as time goes forward. I get more and more of your reports. That's awful. That's awful professional practice. To not even be able to consider whether you've misdiagnosed the pathology because you're practicing below the level of a professional. You haven't told anybody what your diagnosis is. You haven't told the other doctors. So there's plenty of problems. And then I'm going to just look at the licensing boards. How do you let these psychologists get away with this substantially inferior professional practice to all these families who are vulnerable? They have this family court conflict, and the court's deciding things. This is a vulnerable population. They don't have control over their children anymore because of the court's involvement. And the mental health input coming in is vital to solving that. So we should at least be applying the DSM-5 and ICD-11 to the diagnosis in the family, so that a second opinion can come along and say, is that a supported diagnosis or not? Okay. And right now, no, you're not given a diagnosis. You're not supporting it. You're not even considering this stuff. So that's the situation. That's what I'm walking off to on a Wednesday here. So I get my cup of coffee, I'm going to be sending out one report challenging the diagnosis, saying he misdiagnosed the pathology. I'm going to be taking a look at another one saying misdiagnosed the pathology. Got a third one coming in as soon as I get those two out, where I'm likely to be challenging the diagnosis. If it's coming to me as a second opinion, it's going to be in a type of context. People aren't bringing me their, eating disorder treatment things or your substance abuse. They're bringing me court-involved custody conflict where there's a litigation and they're challenging the diagnosis. They're saying you got your diagnosis wrong. So they're bringing it to somebody who knows stuff about diagnosis and pathology. And yeah, they're right. You got the diagnosis wrong because you're not applying diagnostic criteria to your judgments. And that's ethical violations, and that's what's going out. It comes down to a standard 3, violation of 2.04. I do a checklist of applied knowledge. In this case, and when I'm sending out, that's appendix 3. Checklist of applied knowledge. No, they didn't. They didn't even apply the DSM. They didn't apply attachment, family systems, nothing. Okay. And so violation 2.04, that leads to the violation 9.01. That conclusions are based on information technique sufficient to substantiate your finding. And then I'll look at your vita. In this case, I looked at the vita, but also I'll question whether you are competent. And so then show us on your vita where you've got your background, education, training, and experience in the diagnostic assessment of delusional thought disorders, family systems, complex trauma, personality disorder, pathology, just all the relevant domains of knowledge. You don't. Okay. I've seen your vitas. I know what you do. I've worked in psychology my entire life, from working in psych hospitals to put myself through a master's degree and to working as research associate on NIMH projects to heading up my own clinic. Okay. So I've worked all over psychology. I know exactly what you're doing. Okay. As a psychologist, as a professional, I know what your vita looks like. I know how you got there. And you don't have the competence domains. That's why you're misdiagnosing the pathology. It's because you're not competent in the necessary domains. So I got violation of 2.04, violation 9.01, violation of 2.01. 3 ethical violations lead to a misdiagnosis. And we can't even evaluate your misdiagnosis yet because you haven't diagnosed anything. Okay. So let me finish up with when you don't have a diagnosis, what I'm going to be saying on interpreting that as a doctor, a professional level doctor, getting communication from you as another professional doctor. So we're talking doctors to doctors here. When you don't diagnose or provide a diagnosis from a DSM-5, ICD-11 to the situation, that is communicating to me that there is no diagnosable pathology present. Because otherwise, if there was, you would have diagnosed it and told the court and told other doctors, right? So if you're saying there's no diagnosis present, you're saying there's no diagnosis present. From one doctor to another, from a doctor to the court, there's no schizophrenia present. Okay, there's no bipolar disorder present in a parent. There is no child abuse present, because otherwise you would have diagnosed that. That's in the DSM-5. Okay, physical, sexual, neglect, psychological. So there's child abuse present. You diagnose that and tell the court, right? You diagnose that and tell other doctors, right? There's no delusional thought disorder present. Okay, because if there was a persecutory delusion in a parent, you would tell the court that and you'd tell other doctors that, right? And because there's no diagnosis there, you're saying that's not present. Okay, that's what you're communicating from one doctor to another when we're using the ICD-11 DSM-5, that there's no diagnosis present. Okay, so there is no child abuse. There is no delusional disorder. Now, the other thing you're telling me is because you didn't even put it as a rule-out diagnosis, R/O, rule-out delusional disorder. You are saying there's no possibility in this family of a persecutory delusion. based on your assessment. Because otherwise, if there was a possibility, you'd put it as a rule out. Delusional disorder, rule out possible child psychological abuse, rule out possible spousal abuse of the targeted parent using the child as a weapon. You'd use rule outs if that was a possibility. And there's no rule out diagnosis. So that communicates to me as a doctor to doctor, that you have found there is no possibility of factitious attachment pathology. You're saying it's true attachment pathology caused by child abuse by the targeted parent that I'm not seeing, you're not reporting. So it's a misdiagnosis. Okay. Your no diagnosis, you're asserting for a fact that you have verified that there is no delusional thought disorder in the family is a misdiagnosis. You didn't perform a proper assessment for that. And you didn't even consider it. Okay, so that's the situation. It's just a horrible, horrible state of practice. But that's my living right now. So I don't mind you bring me their cases. I'll work up your report, and we'll do this for a while until the doctors decide to start practicing at a professional level. Final thing, just on ICD and DSM. DSM-5 is from the American Psychiatric Association, and it's all psychiatric disorders. And it started in the 60s. And they give a more fulsome description of the psychiatric disorder and the research support under it. And there's several books, research books and other things that support the DSM-5. So that's from the American Psychiatric. The ICD-11 is from the World Health Organization, and it has a code number for all medical and psychiatric disorders. So that's used in billing medically all over the world. Okay, you use the ICD-11 to put your billing codes in, for cancer or high blood pressure or ADHD or whatever is in that ICD-11 system. And basically the two line up. ICD-11 is medical as well. Psychiatric. DSM-4 is more psychiatric and a little bit stronger there. The rest of the world uses ICD-11, and Americans use it for billing. American mental health people tend to rely on the DSM-5 in the world as well because of the more fulsome descriptions of the pathology. But basically they line up. Basically they're the same. They're just code numbers, international, national kinds of things. So factitious disorder imposed on another directly lines up. Delusional disorder, child psychological abuse, all those diagnoses line up. So we need to just start applying professional level knowledge. DSM, no other talk about the PAS people saying we need to get parental alienation in DSM-5. No, we don't. It's already in the DSM-5. Apply it. Okay. Stop. The people just stop fighting about stuff. Just start practicing at a professional level. So with that, I'm going to go off and start reviewing mental health reports. Good luck to people out there. You need a clinical diagnostic assessment for the child abuse. Appropriate differential diagnoses for each parent. Get a second opinion on it because it's going to be a disputed diagnosis. Get a third opinion. That's what we do in healthcare. So with that, take care, everybody.